As Vice Chair of Interfaith Partners of South Carolina, I commend you for dedicating time to further your knowledge of how to support aging and vulnerable populations in your faith community. A statewide organization, Interfaith Partners of South Carolina, or IPSC, brings together people of diverse religious, spiritual, and secular paths throughout our state to cultivate a more harmonious community. Representing 12 different religious and secular paths, we work in solidarity to cultivate relationships of trust, to protect the religious freedom of all, and to act in service with and for one another. Many of the faith traditions that IPSC represents place emphasis on aging and the wisdom that the elderly possess. My faith, Judaism, is no exception. In the Torah, we learn that it is a mitzvah or a commandment to honor the elderly. It says in Leviticus 19:32, "You shall rise before the aged and show deference to the old." Our Midrash, or rabbinical commentary of the Torah, teaches us that, quote, "Everyone who welcomes in an elderly person, it is as if he has welcomed in the divine presence." As such, most Jewish organizations, such as the one that I work for, the Columbia Jewish Federation, have programs and services dedicated to our aging demographic. Rabbi Abraham Joshua Heschel said, "A test of a people is how it behaves toward the old. It is easy to love children. Even tyrants and dictators make a point of being fond of children. But the affection and care for the old, the incurable, the helpless, are the true gold mines of a culture." Thank you for being a true gold mine of the culture in our state.
And now we're going to turn it over to Connie Munn.
Good morning, everybody. It is an honor for me to welcome you to the 3rd Annual Symposium. I want to thank our partners, the South Carolina Respite Coalition and Columbia International University, for working alongside our staff, Kay Hightower and Jennifer Bruton, to organize this exceptional series of virtual webinars for members of our faith-based organizations. We hope that you will take the information that you learned during the next 4 weeks and take them back to your faith communities to create ministries and programs that will assist our seniors and our caregivers. We know that the toll that this pandemic has taken on all of us, but especially our most vulnerable population, our seniors. So I want to thank you again for taking the time out of your busy schedule to come together to learn about health disparities that COVID has affected our senior and our most vulnerable populations. And I also just want to echo what Cheryl and her welcome, and what a phenomenal message for us to kick off this series to learn more about our most vulnerable population and how we can protect them. And Kay, I just want to thank you personally. I know that this has been the heart and soul for you for 3 years now, and you've worked very hard. So thank you for all that you've done. And Rachel, I appreciate all the work that you have done as well. So I'm looking forward to a wonderful next month of series that we're going to be able to learn together. So thank you for having me in this morning.
Thank you, Connie. And now I'm going to introduce Dr. Linda Bell. Dr. Linda Bell received her undergraduate degree in molecular biology from the University of Texas at Austin and obtained her medical degree from the University of Texas Southwestern at Dallas, now the UT Southwestern Health Science Center, where she also completed residency training in internal medicine. Dr. Bell served as an Epidemic Intelligence Service Officer with the Centers for Disease Control and Prevention in the Viral Special Pathogens Branch, and as a CDC Field Officer with the South Carolina Department of Health and Environmental Control, DHEC. After completing her training with CDC, Dr. Bell joined DHEC, where she has worked for over 25 years, holding positions including Medical Epidemiologist, Director of the Division of Acute Disease Epidemiology, and Director of Clinical Services. Dr. Bell is currently the South Carolina State Epidemiologist and Director of the DHEC Bureau of Communicable Disease Prevention and Control, providing oversight for the Bureau's 5 divisions: Acute Disease Epidemiology, Immunizations, Tuberculosis Control, STD, HIV, and Viral Hepatitis Prevention, and Surveillance, Assessment, and Evaluation. Dr. Bell has previously served as a trustee on the boards of the Adventure Children's Museum, Healthy Learners, Heathwood Hall Episcopal School, and Francis Burns United Methodist Church, and she participates in several community, social, and service organizations. Dr. Bell is married to Dr. Myron Bell, a cardiologist practicing in Columbia, and they have 2 children. Please welcome Dr. Linda Bell.
Thank you for the introduction, Rachel, and I'm thankful to the South Carolina Department on Aging and the South Carolina Respite Coalition for this invitation and this opportunity, and I'm pleased to join my colleague this morning to do this joint presentation. So I will share my screen to give a brief presentation. Can you see my slide deck?
Not yet, no ma'am.
Okay. How about now?
Yes.
Okay. So thank you again for this opportunity to address the very important topic of health inequities and health disparities. So I hope to bring to you today an understanding of the health inequities somewhat in general and specific to COVID-19. I will give just a brief overview of COVID-19 to help with an understanding of how we got where we are today and our evolving understanding of this novel virus and its relationship with disparities and inequities. And I'll talk a little bit about our response activities, particularly to address those who are most impacted. COVID-19, or that is the name for the disease that is caused by the SARS-2 virus, and COVID is for the coronavirus infectious disease of 2019. And this was caused by a novel virus. This is caused by a novel virus of the category of coronaviruses in general, which are known to cause illness in humans and a variety of animal species. And there's a rare event where these viruses can make a genetic change and jump from one species to another. They're usually very species specific. But in the rare event where this genetic change occurs, they can become efficiently transmitted in other species. And in this instance, there were animal species in a common market in China, where there's the event where they have live animals of multiple species in markets where there are also humans present who purchase food. This is not a circumstance that we find in the United States, and it is an opportunity for multiple animal species to be in the same space, including humans, and for these viruses to jump from species to species. And this is exactly what happened. This is absolutely not an event that was genetically engineered by humans. This is a natural occurrence that we occasionally see in nature. It's a relatively rare event. And when this does occur, it means that it's a novel virus that humans have not previously been exposed to. And so there is generally universal susceptibility to these new viruses. And if a virus occurs in any place internationally, because of the opportunity for international travel, within a matter of 14 to 18 hours, someone can get on a plane and be in an entirely different continent and introduce the virus to a new population. And it is by this means that these novel viruses spread when they can infect humans rapidly across continents and across countries. And this is exactly what we're seeing. We have experienced previous pandemics, but I will say that the magnitude and the duration of this novel virus is unexpected. And it has resulted in secondary consequences, not only of morbidity and mortality, but it has also resulted in the widespread societal disruption of our economic system, of other consequences for people who are less resilient to survive and have suffered disproportionately from economic disruption, and also from the necessary measures that we put in place to prevent spread. Physical distancing, and that has its consequences for societal disruption and isolation, particularly in elderly, rural populations, and so there are multiple consequences aside from the morbidity and mortality. We have been experiencing this virus now since the end of December, so we're really only a matter of about 9 months, even though this does seem like an eternity. But 9 months is not a long track record to get a complete understanding of a novel virus, but we are learning rapidly. And some of the things that we're understanding is that coronaviruses are generally a respiratory illness, and it was the belief of scientists initially that this would just affect the lungs, the respiratory system, and that it would be spread by respiratory droplets by people who are symptomatic. And what we're learning is that it's not only spread by large droplets that are coughed or sneezed by people who are obviously ill, but it can also be spread in an airborne route. And what we mean by that is that there are much smaller droplets that remain airborne longer than the larger respiratory droplets that fall out of the air more rapidly. It is the basis of our recommendations to stay at least 6 feet away from other individuals because of the risk of being exposed by those respiratory droplets if you're within 6 feet. But there also is a smaller risk of those smaller micro droplets remaining suspended in the air for a longer period of time. And that's the foundation of the need for masks, because it can be spread from person to person. And another important finding is not just by people who are ill, but also by people who are asymptomatic. We are learning that individuals who are infected with the virus, but who do not have symptoms, have the same amount of virus in their respiratory droplets as do people who are ill. And so it's very important for all individuals to wear masks, whether they're aware of an illness or not, to protect themselves from exposure. Other things that we're learning about this virus is that in addition to the respiratory or pulmonary or lung complications, this virus is very unique in that it is causing effects in nearly every organ system in the body. We are seeing gastrointestinal symptoms with nausea, vomiting, and diarrhea associated, but also some of the complications include renal or kidney disease, vascular disease, the cause of strokes in previously young, healthy people without a history of cardiovascular disease, without a history of hypertension or high blood pressure, are sometimes experiencing strokes. And there's another phenomenon called the multi-system inflammatory syndrome in children, or MISC. And the strokes in MISC are both a result of the formation of small clots in the vascular system that affect the blood supply to many organs. We're seeing neurologic symptoms, and the residual complications of the inflammation in these organ systems remains unclear. We're still studying this. For example, there is evidence that there is inflammation in the heart muscle, and the potential for young, previously healthy people with no heart disease to potentially suffer long-term complications of heart disease or other complications. And another thing that we're seeing is there's at times a prolonged recovery in people who get over their initial symptoms, but they have fatigue, shortness of breath, difficulty breathing that can last for weeks and sometimes even months after they recover from the acute symptoms. So some of the studies about this new coronavirus, and these are examples of studies that have been published in a publication from the CDC, the Morbidity, Mortality, and Weekly Report, that looked early on at individuals who were more likely to suffer severe outcomes, to be hospitalized, and the association of these complications with individuals who had existing underlying health conditions. And so this study reported the severe outcomes among people affected, the number who are hospitalized and the characteristics of those individuals. And the importance of these studies is that although they identify the risk of certain people to have more severe complications, particularly individuals with underlying health conditions like existing heart disease, cardiovascular disease, diabetes, obesity, there's actually no mention in these articles of the potential effects on individuals of specific racial or ethnic groups or by other demographics. So it was not initially reported that there are certain members of the population who could suffer more severe consequences just based on their population group or their racial or ethnic background. And this is another infographic from the CDC that shows some of the underlying conditions that put people at higher risk of having more severe complications. So for example, if an individual has asthma, they have a 1.5 times higher risk of being hospitalized than do individuals without asthma. Similarly, for hypertension or high blood pressure, a 3 times greater risk. Obesity, also a 3 times greater risk. For someone with severe obesity, they have a 4.5 times greater risk of being hospitalized. And for individuals who have at least two conditions or 3 or more conditions, have a significantly increased risk of being hospitalized. And those who are hospitalized have a higher risk of being on a ventilator or actually succumbing to the infection. So I'll talk a bit now to understand the health inequities of COVID-19. And just very briefly, some definitions, making a distinction between discrimination and health inequities or health disparities because they're not the same thing. Discrimination is the unjust or prejudicial treatment of different categories of people, especially on the grounds of race, age, sex, religion, or other factors. And it is a disappointing phenomenon that oftentimes people are discriminated against because of specific diseases. We've seen this with emerging diseases and other pandemics to include the HIV virus. We saw it with the Ebola outbreak, where we had an outbreak that involved primarily only 4 West African countries. We had only 4 individuals in the United States who had Ebola. Yet there was widespread discrimination against people who were from Africa, even if they were not from those 4 West African impacted countries, regardless of how long it had been since they had been in Africa, or even individuals who just, as some of the population thought, they just appeared to be from Africa. There was significant discrimination in the Ebola outbreak. In the early stages of the COVID-19 pandemic, there was discrimination against Asians. When we think about disease nomenclature, it's important that we not attach names of diseases to populations of people. Comments like the China virus resulted in significant discrimination in Asian populations in the United States. It actually disproportionately affected those businesses among Asians because of these discriminatory practices. But health inequities refers to differences in the length of life, quality of life, rates of disease, disability, and death, and the severity of disease and access to treatment. So there is unequal treatment in individuals in the population. So our evolving understanding of these high-risk groups is another thing that we're learning. And I actually categorize high-risk groups into 2 areas. Those are individuals who are at high risk or higher risk of being exposed to the virus, and individuals who are at higher risk of complications, as I just talked about. And as we look at these 2 categories, it should be evident that they are, there's an intersection. That there are, by age group, individuals who are at higher risk of exposure. The examples here would be individuals who are in congregate settings, particularly older individuals in assisted living facilities, nursing homes, or adult care settings. But there's also an increased risk of exposure by age group for young, healthy people, because Adolescents and early adults are actually much more likely to be out and about. They are less likely to experience symptoms or have more severe disease, so they can be out and about while they're actually carrying the virus. And these are actually individuals who are less likely to practice the prevention measures. So they have a higher risk of exposure, but the younger people are not in the category of a higher risk of complications where the older individuals are. Certain racial and ethnic groups are actually in both categories. Some minority populations, because of their living conditions, because of their occupations, where they are maybe less likely to work in a setting where they can telework, or they may work in a setting where physical distancing is not possible. They're maybe more likely to have to use public transportation or share rides or live under housing conditions where if there's an ill member in the household, they cannot isolate within the household without the spread in the household. So individuals of lower socioeconomic status have a disproportionate risk of exposure because they're unable to limit their exposures. I've already mentioned congregate settings of nursing homes, but I also include in there the risk of exposure for people in correctional facilities and other group settings. And so social circumstances have a great deal to do with the risk of exposure. And then the risk of complications, I have already mentioned. But I will add one thing. The risk of complications for social circumstances, being of a lower socioeconomic status also means that you're less likely to have adequate access to care, or and if you have inadequate access to care, you're less likely to have underlying conditions better controlled. So your blood pressure may not be controlled. You're more likely to have heart disease and vascular disease and other complications. So that those social circumstances are set up for a risk of complications for people with underlying conditions. And so I asked the question based on that early research and evidence that I showed, that the researchers identified that people with underlying health conditions were at higher risk, but they did not mention specific racial and ethnic groups like African Americans. And this should have been predicted. And in fact, by some people it was. It was understood that African Americans in particular have a higher prevalence of chronic health conditions. Many racial and ethnic groups are economically less resilient. They have limited access to care. And again, the limited ability to minimize exposure due to worksite, transportation, and housing. So the impact on these individuals comes from not just this COVID-19 pandemic, but from longstanding systemic health and social inequities that put some members of racial and ethnic minority groups at increased risk of getting COVID-19 or experiencing severe illness. And the last thing that I will add on this slide that I haven't already mentioned is that these individuals also are subject to chronic stress from their social circumstances. And they are at higher risk of mental illness, anxiety disorders, just from the stress of their social circumstances in general. And there are correlations between anxiety disorder and stress and suicides, and the consequences of the social situations, the isolation, increase in substance abuse are all phenomena that we are seeing now with COVID-19. Again, not related to the actual infectious disease itself. So the impact of health inequities is not just on those racial and ethnic minorities, but it's important for us to understand that when we have a respiratory disease that is spread from person to person simply by breathing, it actually affects the population as a whole if it affects any pockets within the population. It also affects the population at large by exhausting available resources that we are pouring into controlling COVID. We all suffer those consequences. We all share the risk of disease exposure if we cannot adequately control it in any population group. We are experiencing the societal costs that I've mentioned, the impact on the essential workforce, and the impact of the quality of life for all of us as we're all just yearning to return to some sort of normalcy. So reducing the impact of COVID-19 among racial and ethnic minorities is multifactorial. It depends on the faith community, on family structure, and cultural institutions are very important sources of social support for individuals and communities to take action to prevent COVID-19, and also to care for those people who are sick and to care for other community members who are coping with the stress of their loved ones, their community members who are sick. And this important infrastructure is needed to address these populations, including in emergencies, but also to improve their day-to-day life. To do this in part, DHEC has had a number of targeted responses to address what we are identifying as significant issues. We're working with congregate settings in nursing homes to make sure that testing is available, to make sure that infection control practices are there to protect the residents and the workers. We're working with correctional facilities. We're providing targeted response to make testing available when we find hotspots. And some of these, surprisingly, are in dormitories or apartment complexes where our young people congregate and are at increased risk. And we also have widespread messaging to address what we identify with hotspots to make sure that people understand their risk and we can address it. We work with specific population groups. Hispanic and migrant workers, we've done a great deal of outreach to let them know about their risk and to help their employers reduce the risk in these populations. And we've done many, many targeted interventions in African American communities, working with the mass media, with faith leaders, targeted testing, working with historically Black colleges and universities, and creating mobile sites to serve the needs in underserved communities. This is just an example of how we've used data to target testing, and I won't go too much into that because my colleague will talk a lot about the data. But we've done a great deal of faith-based outreach because faith leaders are trusted individuals in the community, much more so perhaps than our policymakers, political leaders, scientists. And so the importance of faith-based leaders in helping us control COVID-19 cannot be underestimated, and that's why we've tried to work very closely with them to make sure that they have credible messaging to give to their congregants. We've done telebriefings with faith-based leaders. We have emailed guidance to local church leaders to help them have prevention measures in place when they have their meetings and their services to help them reduce the risk. We have had discussions with state level denominational leaders and guidance for possible return to worship. And all of this guidance is actually posted on the DHEC website. I won't go too much into this because I don't want to run over time, but I've already talked about significant community outreach that we've done. We do frequently refer people to our website, and we're also cognizant of the fact that we do not reach everybody just with technology. That for people with disabilities, people in rural areas who do not have adequate internet access, with media outlets that better reach individuals with culturally competent messages and from messengers that they trust, are all part of our communication strategy to reach at-risk populations in the way that that they like to receive their information. So I won't talk more about public information. We do recognize that COVID-19 is going to become an endemic disease, that we will not get this to go away completely, and we have to sustain our response activities. And in that, we have to continue to address at-risk communities through engagements. And DHEC has convened a community engagement team. This is a cross-functioning team of communications experts, environmental affairs experts, public health and healthcare quality professionals who deal with congregate settings. And we've actually developed a planning document, the overarching purpose of which this plan is to support short and long-term community engagement strategies aimed at addressing health equity issues and promoting healthy people living in healthy communities. Before I end, because I always like to give a prevention message that is appropriate for everyone, and that is the evidence for masks, and to let people know that we can control COVID-19 individually and in populations. And I bring this to your attention because there are lots of questions about why we recommend masks, and in some jurisdictions why masks are required under certain ordinances. And that's because there's abundant evidence that masks do work. It has been published in peer-reviewed literature. And in fact, in DHEC, through our own studies, we have looked at the control of COVID-19 in jurisdictions that have mask ordinances as compared to those that do not. And in our third analysis, we've actually have evidence to support other research that has been published that masks do work, because in these communities, they see a quicker decrease in COVID-19 as compared to communities that do not have mask ordinances. And so I want to reinforce the message that we can control COVID-19. Protection relies on the avoidance of exposure. Stay home as much as possible, but practice your normal activities by practicing social distancing, the correct use of masks universally when you're out and about, indoors or outdoors if you can't physically distance yourself from others. And frequent cleaning and disinfection and hand hygiene is very important. So we just ask everybody to wear a mask, to be smart and stay 6 feet apart is what I like to tell people. And I think that concludes my presentation. I thank you again for the invitation. I'm happy to entertain questions at the end of the session.
Thank you so much, Dr. Bell. I was thinking that we would hold all questions until Dr. Eghtedary was able to complete her presentation as well. And thank you so much for that wonderful information. It's so important, and I appreciate your time. Our next presenter is Dr. Eghtedary, and she is the Bureau Director for the SC Department of Health and Environmental Control, Population Health, Data Analytics, and Informatics. Dr. Eghtedary has 22 years of public health leadership experience in maternal and child health, data analytics, and technology management. She is deeply committed and has done extensive work to bring health equity to the forefront of every public health conversation. Thank you. Dr. Eghtedary, I believe you're on mute.
So it appears that we lost Dr. Eghtedary for a few minutes. I'm sure she's gonna be joining us shortly because I don't see her. Ah, there she is.
Good morning.
Good morning, Dr. Eghtedary.
Can you hear me? It seemed like I got disconnected for a minute. I don't know if that happened to everybody else, but.
Yes, we can hear you. We can hear you now.
And I've just made you the host so that you can share your screen. Thank you.
Okay, can you see my screen?
Yes.
Awesome. All right, good morning, everyone. Thank you for inviting me to your symposium series. Thank you to South Carolina Department of Aging and the Respite Coalition. Thank you, Dr. Bell, for that wonderful presentation. And I will talk to you a little bit about health equity in South Carolina, and also more specifically regarding COVID-19. Equity, World Health Organization has defined it as the absence of avoidable, unfair, and remediable differences among groups of people, whether close. Those groups are defined socially, economically, demographically, or geographically. And health equity implies that everyone should have a fair opportunity to attain their full health potential, and that no one should be disadvantaged from achieving that potential. And social determinants of health are the major factor for health disparities. And these are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the condition of daily life. So there is a huge difference between equality and equity, and providing the same services, same systematic kind of policies to everyone, regardless of their need, is not equitable. So that is what basically the focus of the talk from my portion. We'll look at some health disparities before COVID, the data. So when we look at health disparity in life expectancy, within a very short distance, you will see a wide range. There's a 20-year in life expectancy difference between just in down the road in a very small neighborhood. So tell me where you live and I'll tell you how long you live. That's really the heart of the difference in health equity and the impact of health disparity. So when we look at the population in South Carolina, we can see very closely where that population has changed between 2010 to 2018. And you can see that there is a huge population drain for majority of the state, while some of the states have increased in their population density. As far as race ethnicity goes, close to 65% of the population is white, and the other 35% are of various race ethnicity, with Blacks being 27.3%. This is important as we discuss the impact of health disparity and COVID-19, remembering that 27.3%, only 27.3% of the population in South Carolina is Black, and only 5.8% is Hispanic. There is a huge difference in when we look at delay in healthcare due to cost by race, ethnicity, and gender. And you can see that there is the Black population and the Hispanic population have delayed medical care due to cost. And this is also apparent when we look at the median age of death, both in male and female, that there is a big difference in the median age of death by race ethnicity. And the biggest difference is in heart disease. The Black population have the highest rate of heart disease, and also when we look at other conditions like stroke and diabetes, they have also a higher rate. So when we look at disparity with COVID-19 and we look at some of the predisposing conditions of complexity of COVID-19, we see that the Black population already has some of those conditions. one of the major part of knowing a population and a community's health, public health, is looking at their maternal and child health. In South Carolina, there is a big difference in infant mortality. Black children are dying, or infants are dying more than twice of a rate than the white infants. And this gap is increasing between 2009 and 2018. So as you can see, the rate, not only the rate has increased of infant mortality, but the gap also has increased. So there's also the difference between the geographic, which is rural and urban areas, and also where the Black population, there is a higher rate of Black population. So this, as we talked about the stroke, higher rate of stroke, there's a difference in stroke death among non-Hispanic white and non-Hispanic Black. And again, that gap has increased, it's widened in 2018 compared to 2009. So this is not just rate of stroke, but the stroke death. And looking at the geographic differences in stroke death as well. And then you can see this is really, it comes in various maps that we will show you, that PD region, because of higher poverty rate and rural and health, basically healthcare accessibility, there is a higher rate of that disparity. So I want you to take a look at this latest county health ranking that came out in 2020. And I will compare two of the counties in South Carolina. Beaufort County was ranked #1, and Lee County is ranked 46. So the first and the last ranking. The population size, there is a big difference. So also the premature age adjusted mortality also is the 260 compared to 650. Low birth weight, 8% compared to 13%. Exercise opportunity, 83% compared to 39%. Obesity in adult, 24% in Beaufort and 40% in Lee County. And primary care physicians availability, 1,430 per one person, where in Lee County is 5,780 per one person, per one doctor. And preventable hospital stay, there is 4,187 compared to 7,364. And children in single parent household, 34% compared to 61%. Children in poverty, 20% compared to 43%. Some college education, 64% compared to 37%. And household income, 65,800 compared to 33,200. So look at all those variable socioeconomic and health disparities. And now, if we look at the difference in racial differences, that difference is very apparent where those disparities come from. So the white population in Beaufort County is 68% compared to 32% in Lee County, and the Black population 17% in Beaufort County compared to 63.6% in Lee County. So just by looking at this simple ranking, county health ranking, you will see that at least in South Carolina, the difference in health disparity is an issue of racial disparity. And that is very apparent with this just a small look at the data. So when we look at COVID equity, you have heard, we all have heard many times that we're in this together. And the question is, are we really in this together? If we are in this together, what's the difference between people who have preconditions to disease and also predisposed or already based on their poverty level, based on where they live, based on their race, their age, and their gender? So there is that how you come into the disease state that makes a huge difference. So there is also looking at various data. Our dashboard at the DHEC website has extensive amount of data when we look at COVID-19. And this is just looking at the 10 leading counties in COVID-19 cases. For the top portion is for the from March 2020 to September 27, which is just this week, and then looking at the last 14 days. There is a difference and there is a shift in various counties where those cases appear, depending on the activities and depending on some of the mask ordinance and various issues that's going on within that county. This is also showing the level of leading counties with newly reported cases. This is basically between September 14 and September 27. And there is a difference between counties that have higher newly cases of among whites and newly cases among the Black population. And the two graphs below also show that 14-day difference in various counties. For example, Allendale both has really the highest rate of newly cases for both Black and white. But then the second one for the white population is in Barnwell, where for the Black population is in Dillon County. So this really provides various very specific information to our public health providers, to our community leaders to be able to basically address and provide resources to those communities. And we also look at the data at the regional level, and you can see that this really shows our latest numbers show that there's a huge difference between the Black cases, the cases in the Black population compared to the white. And this difference, the number is highest in PD for both the white and the Black population. And also when we look at the disparity in low country, there is a wider gap between COVID cases among the Black population and the white population. Now, age has become a huge factor in COVID-19, not only COVID-19 cases, but really the death in COVID-19 as well. So as you can see, depending on what is going on in this state and depending on what is going on in different counties, the age varies as well. So when we had that kind of around May and earlier in June, the age level has decreased among COVID-19, and these are just average age among younger population. But those, the cases with 65 and older, there is the average age of COVID-19 in whites are 40. So the average age is really similar between the Black and white. And majority of the, in white population, the majority of the cases are happening in the 20 to 30-year-old cases. And then when we get to above 31, we see that that number is higher in the Black population. And then again, when we go down to the older population, there is a decrease in the Black population, and that could just be simply because of that life expectancy that we talked about earlier. So there is a higher number of older white population in South Carolina that there is Black population. And looking at counties and COVID-19 cases among those higher than 65 years, we will see that in Pickens County, that has the highest rate of those in 65 years of age, with 431 case, almost 432 per thousand. So that's a huge number when we look at Pickens County. And then when we look at Jasper County, that has the lowest rate of cases among those 65 and older, with only 50.3 per thousand. And these are really looking at the latest data that we looked at before we developed this presentation. When you go to the website, you'll see the data basically from the night before. That data is very up to date. And the other issue with COVID-19 is also these long-term care facilities, that kind of group living that created this issue with number of cases, increasing number of cases, and also death. So when we are looking at the data, there is 8,767 cases in long-term care facilities, most of which are amongst residents and also among staff. That's a high number. About almost 3,000 of those cases are among staff within those facilities. So you can see how that transmission can go in and out of the residents easily. There has been 1,286 deaths, unfortunately, in these long-term care facilities. However, the number of deaths is mostly among the residents because the staff are of the younger population. And 37.9%, almost 38% of the death in South Carolina is among the residents of long-term care facilities. COVID-19 hospitalization is another area that is really to pay close attention, and that is because of this hospitalization by age group. The higher age group tend to be hospitalized, and also that is where the higher number of death is. So there is a big difference also again in the PD region, where you see higher rate of COVID-19 hospitalization. So when you add up all those variables for PD region, you can see how that kind of adds up, and there's various level of risk in that area. COVID-19 death, this is where the heart of the disparity is. So even though there is a disparity in COVID-19 cases, there is that disparity in cases does not really explain the disparity in death. So there is almost twice as many Black population that dies of COVID-19 compared to the white population. And this disparity also is very apparent within the various regions. And as you can see in the PD region, again, that disparity is very, very large, and the number of Black death is huge. So if you look at all of this and just kind of also go back to the original, that first slide that I showed about the population, that there is really only 27% of the population in South Carolina is Black. But then when you look at the death rate per 100,000 of the population, you can see that really huge disparity. There are various COVID-19 related health equity products that we also developed that are specific to various disease conditions or various population. For example, one in Hispanic population and COVID-19 and the impact of diabetes, and also the difference in testing as well. And these are also updated when we look at the website. So these are the resources that are available in our website, various dashboards. Unfortunately, I can't click on it because of the network availability. But if you click on it, I think, or copy paste, when you get this presentation, you'll be able to go to that specific dashboard and look at the various data. So the COVID data page on the DHEC website has all the various type of both on testing and cases and hospitalization. And there is a county dashboard that is very comprehensive and specific to COVID-19 long-term care facility dashboard as well. We are currently developing, we have developed a COVID-19 equity dashboard. We are just expanding that to include various disease and disparity that exist in even non-COVID conditions. So going back to our original basically question, are we in this together in reality when we look at COVID-19? We are in this together because there is really no public health without health equity. So if we look at COVID-19, that has become a huge revealer of health disparity. It is very apparent because it is like history in the making right now in front of us. It's not abstract anymore. So before COVID-19, when we looked at health disparity, when we look at racial disparity, economic disparity, there was this, there was this kind of talk about whether it is real or not. And in America, in the richest country in the world. And there was this agreement in that. When we look at COVID-19, we can't deny it anymore. It's in our face, and it is showing thousands and thousands of our neighbors, our community, our families that are dying. So it's very real, very tangible, very today and right now with each breath that we take. And it shows that if one of us catches it, it's very easy that we can give that unknowingly to our loved ones, to our community, and it's transmitted easily. So we are in this together, and we cannot ignore health equity anymore when we talk about public health. So just a few days ago, on September 22nd, there was Executive Order 13950 that talked about, that was actually signed on combating race and sex stereotyping. And what that does is actually preventing people to provide any type of training on advancing diversity and equity and inclusion, and also providing any kind of federal support and funding, basically cutting all federal funding to provide those kind of services. So this is huge news, basically. When we are actually talking about health equity, then at the same time, we have issues that if we talk about health equity, that means that we are kind of stereotyping various sex and racial issues. So it's quite interesting times for us. There is no going back. As we talk to various equity partners, there's no going back. This is where we are. And COVID is real, and it has really kind of opened that curtain that we have to face it. And thanks to all of you who are partnering with us at various communities, and also the Department of Health and Environmental Control, and especially Dr. Bell and her team. It's an amazing, really, opportunity for us to not only combat and respond to this COVID-19 right now, but also long-term, to talk about immunization and how we are going to equitably make sure that that vaccine is available to people that are most vulnerable. Thank you again for inviting me to your symposium, and I will take any questions when that time comes.
Thank you so much, Dr. Eghtedary and Dr. Bell, for that fabulous, fabulous, fabulous presentation. I will start it off with the first question. Would it be possible to share the slides with our attendees? Because
I'll be happy to share my slides.
Oh, thank you so much. And Dr. Eghtedary?
Yes, definitely. I will share the slides with you. I know this is recorded, so you will have the slide deck to put on your website or send to the participants. And Rachel, I made you host, so you're in charge.
Thank you so much. So we do have one question from the Q&A feature, which is from Yolanda Welbon, which is, with all of the knowledge that we now have about COVID, and knowing that more and more children are being raised by grandparents, is it a smart decision to have children return to in-person learning in South Carolina at the start of the flu season?
I can try to address that question. And this actually comes down potentially to individual family situations and individual family decisions. But I will say that in our school systems, especially in primary education, the measures that the Department of Education has put in place in schools to assure the use of masks, physical distancing, environmental cleaning, and all those recommended measures make our schools oftentimes a safer place than the community in general. So with the opening of schools here in South Carolina and also in other states, what we are seeing is that, yes, we recognize that we have had cases of COVID in school children and in staff members. And here, especially early on in South Carolina, we haven't really identified ongoing transmission in a school setting. Yes, we have identified cases and we're posting that information, But many of these cases who happen to attend school are community acquired. So that we have to remember that all of our schools are part of the community as a whole. So that if the children are in school where masks are required, physical distancing and so forth is required, perhaps the risk of transmission is sometimes lower than it is in the communities where those really stringent measures are not universally in place. One of the things that we have identified though is that extracurricular activities seem to be a bigger risk. We are seeing cases with after school activities, sporting activities and things like that where those measures are not in place. So I do emphasize the importance of practicing those measures in the community. But, for the question though of having a grandparent in the house or in the family unit and a child attending school, that's when I want to draw attention to the fact that many of these families have to make individualized decisions. If you have a family member that is at increased risk because of an underlying condition, or if you live in a home setting where it's not possible to physically distance yourself, or if you have family members who are out and about and are not practicing the recommended measures, they're not wearing their masks and they are not physically distancing and they're participating in large groups. Those are all things to consider when you're making your decisions. And our schools provide a very important resource for education, for food, for childcare, and so there really is the need for individual families to make those decisions, and the school districts are doing, I believe, their best to provide a learning environment that meets many needs. You can have hybrid learning, face-to-face learning. Many schools are moving to that. So our goal really is to reduce disease activity in the community as a whole to keep us all safe in all of our settings.
Thank you, Dr. Bell. Does anybody have any questions? I'm monitoring, Rachel and I are monitoring the question and answer spot, so please put your questions in there. Dr. Bell, I have a question for you that we've gotten from lots of churches, since we don't have any other questions. Is the time now for churches to safely reopen? I know this is very a question that many of the faith leaders, churches and other places of worship, can they go back to in-person worshiping?
Yes, hey, thank you for that question. We do get that a lot. And one of the things I think I neglected to point out when I talk about the risk of exposure is how we define a close contact. And that's somebody who's been in close contact within 6 feet for at least 15 minutes. And so church and religious services can be a special circumstance because you're not necessarily in a setting where you can control that environment. You may be sitting in a sanctuary and you are not able to get up and move away. If you can't control the the individuals in the congregation who are wearing masks, then you have a higher likelihood of having a exposure time that's more than 15 minutes because most religious services last at least an hour. So the risk of exposure is increased with the duration of contact. And one thing that I've seen in some sanctuary settings is that they think that the distance of 6 feet is just from side to side, but it's actually, I want you to think of it as it's a radius of 6 feet around you. So you have to space out the physical distance of 6 feet in the pews, not just laterally, but in front of you. So you really have to stagger that space. Many of our congregations have older individuals who are at higher risk. So we have provided guidance for religious services to make them as safe as possible. One of the big concerns is we have seen clusters of illnesses associated with religious services, especially funerals, where people in mourning just feel the need to comfort one another and make that close personal contact. And it's a great concern that we have seen transmission associated with a number of funerals in South Carolina. So I do know that many churches are, churches and sanctuaries, temples, synagogues are making virtual services available. And so again, people have to make their individual choices, but I ask the faith leaders to convey to their congregations, what works best for the congregations, but to do everything they can to make sure that those measures are in place. I know that not all congregations are necessarily doing that, and it is a risk. So please be safe as much as possible. And I can refer faith leaders to the guidance that we have on the CDC website and the DHEC website.
Thank you so much, Dr. Bell. Do we have any more questions? I don't see any questions. So I will ask another question. I'm not sure if this should be addressed to Dr. Bell or Dr. Eghtedary. A lot of our caregivers have many care of their loved ones have Alzheimer's disease. Are you seeing any special links between COVID and Alzheimer's is the first part of the question. And the second part of the question, do you have any special tips for for caregivers on dealing with people who have Alzheimer's, who might not understand about the masks and the need to social distance?
I can defer to Dr. Eghtedary as to whether or not we're actually collecting any information that would speak specifically to that, and I can, after she comments, I can talk a little bit about that caregiver situation, disease transmission.
Yeah, okay, that is a great question. Because of really data availability and the number, it's difficult to go to some of the diseases more specifically to look at the impact. So we don't have anything specific to Alzheimer's, but I will ask my team to look at it and give me some indication of if we have that available, but at least it may not be large enough to publish, but at least we can share with you to give you an indication of what's going on. But yeah, that's the reason when we don't publish information is because of small numbers and being able to safeguard the identity of various populations.
Thank you. I wanted to clarify the CEU process. So if you are a social worker, this webinar has 2 non-contact social work hours available. And we will confirm your attendance if you'll email jbruton@aging.sc.gov, and she will send you your certificate for your 2 CEU hours. So please, again, if you're interested in receiving social work non-contact CEU hours, please contact jbruton@aging.sc.gov. And I see another question in the chat.
Rachel, Dr. Bell didn't answer her part of the question on tips for caregivers with Alzheimer's.
Oh, I'm so sorry. Excuse me.
Well, sure. And I don't know how much this will add, but I guess I would recommend that we think of individuals in 2 settings. They are in congregate living settings. I mentioned the nursing homes, and so many of the individuals in nursing homes are suffering from Alzheimer or memory loss. And we do recognize that this has been a very significant issue for the restriction on visitation for individuals in nursing home settings in general, but the understanding for people who are suffering from memory loss to understand those circumstances. And this is one of the greatest challenges socially, because they rely entirely on the staff in those facilities to provide their care, to connect them with their loved ones. And when they have those memory issues, this is just a devastating consequence for those families. But they are necessary measures because, as Dr. Eghtedary pointed out, when we look at deaths from COVID, one of the highest rates is among individuals over the age of 65, and in fact, in long-term care facilities is one of the settings where we're seeing the highest rates of death. So the importance of preventing the introduction of disease from the community into these facilities is why these measures are in place. But I will speak to those individuals who are in home settings. This is a personal experience. I happen to have, my son is a college student, and I have a very close family member who is suffering from progressive memory loss. And we cannot make that risk of exposure. So the contact with, between my son and the family member is just, FaceTime. That's the only way that, with him being on a college campus and what we understand about transmission in young adults in college settings, even though they're being tested and whatnot, the potential that he could be asymptomatic and just go to a loved one and give a hug or something like that, it's just a risk that we cannot take. And, technology is hard for older people, especially with memory loss. And so, that family member doesn't always understand why, I, can see, my loved one on, is this the TV I'm looking at? So it's just, from personal experience, it is a real challenge. But we must keep them safe and protected from exposure.
Okay, there is a question that's in the chat. In the PD, I think this would be directed to Dr. Eghtedary. In the PD, there is a Native American tribe known as the PD Indian tribe who reside in Marlborough, Chesterfield, and Darlington counties. Is the state of South Carolina tracking this population? And if so, how has this affected this population culturally, economically, and to their overall health? And I would also include the Catawba, also ask about that tribe as well.
Yeah, that's a great question. We do look at overall the Native American populations and definitely see higher rate of this disease has impacted the various tribes and communities within the Native American for similar reasons as it is for the Black population. So it's higher cases and also the higher number of deaths. We don't publish that information just because, again, for that being identifiable for that population because of the small numbers. I know that we have had close communications, and Dr. Bell can talk about that, with various communities of Native Americans and in providing services and responding to COVID-19, providing testing and also masks and various services. And I don't know if Dr. Bell has anything to add to that. And also, I just want to say that we are also working with the Minority Office of Minority Health to see if there is a way for us to be able to analyze the Native American data more specifically.
Thank you, Dr. Eghtedary. The only thing that I'll add is that we are making sure that through community engagement that we involve Native Americans in our planning for communications outreach, and actually very specifically, didn't mention this at all, but as we look to the potential availability of a COVID-19 vaccine in the fall, we have a planning group, a vaccine advisory committee, where we are bringing together stakeholders across the community spectrum. And in that, we are including a specific representative from the Catawba Indian Nation, Chief Harris, who's been invited to help us make sure that our communications about the vaccine and the risk in those populations are communicated through leaders in those communities. And we have other plans for engagement of other Native American tribes in South Carolina. The important thing is to include them in the plans and make sure that we have their input to make sure that we have messages that that resonate with their populations and come from credible leaders that they recognize.
Thank you. Anita Atwood also has a question. If a senior feels claustrophobic about wearing a mask, what are the options, especially if they have upper respiratory diagnoses or breathing issues? Also, seniors with dementia or Alzheimer's disease might experience high anxiety and not understand why they have to wear a mask. So do you have any suggestions for caregivers, both family and professional caregivers, on ways to address those issues?
Yes, what I would say is if there's resistance to wearing a mask, or if there's a health concern, and I will say that health concerns, the belief that it will reduce your oxygen or something like that, those are actually myths. But for individuals who have claustrophobia or can't wear a mask or don't understand, then it's ever more important to protect them from exposure from all other means. So it would be very much recommended against, if you have a senior who does not wear a mask, to have them out and about. So if they're not in settings where they can be protected from potential exposure, unknown exposure to somebody who may be asymptomatic, I can only emphasize that part of the protection becomes ever more important. There are other measures that are less effective but better than nothing, like face shields, where they can wear a clear shield that covers their eyes, nose, and mouth, but they can see through it. But it does not offer the same protection against inhaling respiratory droplets. So those are some considerations. And also, it really is just patience and, having a caregiver who's understanding and can sort of talk them through and maybe let them try the mask in the house and increase the amount of time slowly, that if you can wear this mask for just a few minutes and then we'll take it off, and then let's put it back on again for a few more minutes to get them used to it, and then maybe take them outside in the front yard, but not around anybody else, and let them wear the mask. So just to reduce the anxiety about the claustrophobia, and to the extent that they can understand, talk through with them why it's so important. They might not understand the mask itself, but we're doing this to protect you, and we can't let you get sick. So it just depends on the conversation and who's delivering it, and just a great deal of patience.
See, we have some questions in the Q&A. Oh. All right. And this is from Jennifer Bruton. Somebody had said that Jennifer's email had bounced back, that she's on leave, but she's participating in this thing. So I'm sure she will get back to you when she's finished with her leave. Is the health in the health rankings of two counties, Beaufort and Lee, being the highest and lowest, were trails and other active, healthy lifestyle options taken into account? Then Jennifer goes on, I asked this because I know Beaufort has the Spanish Moss Trail, which crosses over several socioeconomic lines and is widely used by all.
Yeah, so that one line where it talked about resource availability for exercise, that considers all the various parks and what is available to the public, to everyone, for exercise availability. So that there was a huge difference between Beaufort County and Lee County. So that does consider.
Thank you, Eghtedary. I think I have, since I don't see any more questions, I'm going to ask one final question addressed to Dr. Bell. There's been a lot of confusion about vaccines in the press. Could you tell us when to expect vaccines, or kind of what the status is vaccines and your thoughts on vaccines?
Sure. What I can tell you about the vaccines is that there are actually a number of vaccine manufacturers who are currently in various stages of vaccine development. I can also tell you that the development of those vaccines in those stages is no different than the measures that are always taken with vaccine development. So part of the message that this is moving to market and moving to administration in the public faster than is safe is a myth, because the vaccine manufacturers have committed to going through the same research, development, clinical trials for the effectiveness of the vaccine, clinical trials for the safety of the vaccine, and then monitoring both the effectiveness in preventing disease and any concerns about safety. The reason that these vaccine manufacturers are able to do this much more rapidly than is what we're usually used to is there are several reasons. One is that the genetic makeup of the virus had already been mapped out. So with other diseases, they have to figure out what the actual virus's genetic code is. But from previous coronavirus outbreaks, they already had the genetic makeup. So that was a jump start with the research and development. The other thing is that the research and development is a very costly investment for vaccine manufacturers. And in this instance, the federal government said that they would make vaccine manufacturers whole. In other words, whatever they invested in research and development, they would recover those costs essentially. So that usually what happens after market and negotiating, or vaccine manufacturers deciding if it's sort of worth it to bring something to market, has also already been addressed. And the other thing is just the vast investment in this. So there are many scientific advances with the development of different approaches, different types of vaccines, working by the protein coats on the virus or the genetic material inside the virus, are all in development. And so having said all that, we're told that there is the potential to have a limited supply of vaccine available as early as the beginning of November. We do anticipate that that will be a very limited supply, and because of that, the federal government is recommending that we target individuals who are at highest risk for exposure or complications first. That would be healthcare providers who are required to have face-to-face contact routinely with people who are sick, and then older individuals who are in nursing home settings or have underlying conditions, and essential workers in the community. I actually mentioned our vaccine advisory task force, and so we will be working with that task force to help make decisions about the ethical and equitable distribution of vaccine supply to populations when the supply is limited. And then as the vaccine supply increases, we will reach out to other members of the population to get better coverage for the population as a whole when there is a larger supply of a variety of vaccine types.
Thank you. I also have one last question. Many of the people that are attending the webinar today are direct service workers, either through healthcare or social work and working in social service agencies. And so we frequently come in contact with clients and consumers who might be at higher risk. And what suggestions do you have for allied health professionals on how they can promote safe practices regarding COVID-19 and also work to decrease health disparities among COVID-19, and any other suggestions that you might have for allied health professionals?
Well, the protection measures don't change. There is a great deal of interest in the vaccines for protection. Before we get widespread coverage, that it's actually going to be quite some time. I mentioned those early doses, but it will be well into 2021 before we have enough vaccine to offer adequate protection in the population. And so until that time, we have to rely on these really low-tech measures. We say they're low-tech, but they're actually very effective. So this is my broken record, but I keep saying it because it actually works. Masks do work. Continue to wear your masks. Physically distance yourself from those respiratory particles. Reduce your activity with larger groups, because when we continue to have disease transmission in the communities, you increase your risk of exposure. Now, how to convey those messages to others? We really rely on community leaders at every level. So this could be the individual directly within your community who you trust. We make sure that they have messages and not myths, that they don't convey information that they find on social media and things like that. It's really disappointing to see the perpetuation of messages that are wrong. So our role in public health is to make sure that we have accurate information available, that it is at a low reading level so that it's well understood across the population, that those messages are translated into multiple languages and provided in multiple formats, and that we use mass media through media outlets that actually reach specific population groups, and through forums like this. This is why I just, before I go off here, I just have to thank you sincerely for creating platforms like this. Are so important. It gives, I hope, an opportunity to get questions answered directly that can be taken to the broader groups and constituencies that you all represent, to make you aware of information that's available in a lot of formats, and to make people aware that the health department is here as a resource. But there are other state agencies that we partner with routinely. So to bring in the South Carolina Respite Coalition and the South Carolina Agency for, I'm sorry, I won't get the name right here, Kay, but other state agencies are having a very important role in these partnerships and these collaborations. And these are just tentacles of collaboration that go out into the community from their trusted resources. If they don't feel like the federal government is credible or the health department, they have their community leaders that they trust and can go to. We just want to make sure that our messages are available to them to help us get the word out that you can control COVID-19 spread.
Thank you so much.
Thanks. Thank you so much, Dr. Bell. It's the South Carolina Department on Aging. I know that you guys are a huge, DHEC is a huge agency and a very, very valuable partner. Once again, on behalf of the South Carolina Department on Aging, I would like to thank you, Dr. Bell and Dr. Eghtedary, for such a fabulous presentation. We really learned so much, and I'm sure all of the attendees benefited from it. And once again, we will be happy to send out to your PowerPoints to anybody who wants one. So we would like to thank you. Would like to also recognize and thank Connie Munn, who is the director of the South Carolina Department on Aging. We are one of the newest cabinet level agencies, and she's our director, and she started out by offering a greeting. Also on the line is Ms. Anita Atwood, who is the director of division director of the Community Resources Division of the South Carolina Department on Aging. We would like to thank her. And also Jennifer Bruton, who is the Family Caregiver Support Person Program Manager, who's at the South Carolina Department on Aging. And we would not be here without her contributions from her. Next week, we have another upcoming webinar that I'm so excited to announce. We will be resending invitations to it. Again, you will be able to get CEU hours for those who want to do it. Next week, the focus is going to be on fabulous programs that the faith community is doing to help seniors and caregivers. We're going to have Melanie Dalton from Phoenix Mobility. They have a fabulous transportation program that is working in Richland and Lexington County. We're going to have a representative be talking about a fabulous program that St. Paul United Methodist Church in Kingstree has called the Break Room. When it was open, it was a special place for seniors with Alzheimer's disease that churches have. Also on that committee is going to be Stan Means from Greenville County's Elder Source Ministries and Mary Tudoro from the Heart of Caregivers. Those are some other excellent programs. These are fabulous panelists. The panel would be moderated by Scott Adams, who is the Dean of the School of Business at Columbia International University. So we're so looking forward to that one. Rachel has the links. Then on October 15th, we have a phenomenal panel put together by Roger Acton of Victim Services. That's going to talk about all kinds of ways that seniors are exploited, and that panel is going to focus on all different types of exploitation of seniors, including human trafficking, which is a huge problem in South Carolina. On the October the 22nd, we're having another panel that's going to be focusing on caregiving. We're going to have people from throughout the lifespan talking about how their struggles and how they overcome the burdens of caregiving. And our final culmination of our October symposium will be on October 29th. Prisma physician Dr. Rachel Brown will be telling us all how to deal with burnout. So I for one, cannot wait for that session. So we look forward to seeing you again next week. I want to tell my wonderful partner in crime, Ms. Rachel Hatton, who is just a pleasure to work with. And again, a thank you to Dr. Bell and Dr. Eghtedary. Thank you so much. Rachel, do you want to add anything before we do the final goodbye?
No, I just want to thank everyone for attending. And if you have any questions about any of the future symposium events, please feel free to contact me at rachel@screspitecoalition.org or info@screspitecoalition.org. Thank you again for attending, and we look forward to the future events in our series.
Thank you, Dr. Bell and Dr. Eghtedary. Thank you, everyone. Have a great day.